speaker, I want to welcome Andrew Landstrom, who spent a bunch of time with us here, but he's going to come up and speak to us a little bit about personalized medicine. And so, Andrew. Is it loaded on here? Yeah.
Well, thank you, Jeff. And I'll just echo some of the gratefulness that was talked about earlier. I'm very grateful for the SADS Foundation and for Mike Ackerman for kind of bringing us all together. It's a wonderful, wonderful organization. I'm very grateful for the TCH folks here, Jeff Kim, Christina Miyake, and the other folks who have hosted us. Many of you may know that this is one of the best places in the world to get cardiac care. And so for them to host us in this wonderful place is a real treat. And I'm grateful for all of you. You all took time out of your busy lives to come here. Many from, it sounds like, very far away. And so I want to thank you for being here. Thank you for taking the time. And I hope over the next few hours that you take something from this that maybe gives you a little bit more about the diseases that you all grapple with every day. Maybe nudges you into a role of maybe leadership and advocacy in this space, because people like you are sorely needed to help others, because you all get it, you all are here, and thank you all for being here. It's my pleasure today to talk a little bit about precision medicine in SADS disorders, from predicting those at risk to individualized therapy, and we should have time at the end for some questions and answers if it fits the agenda. I have no disclosures or conflicts of interest, although you should know that I do receive salary support from the federal government and not-for-profit organizations, as does my research lab. We're going to talk about three things today. Since I'm the first person up this morning, I'm going to share a little bit of sort of background information to kind of make sure we're talking about the same thing when we're talking about SADS as a genetic disease. We're going to talk about genetic testing and how this can be used to individualize your care. And then we'll talk about how we might be able to predict SADS conditions early in life. And this is something I'm very excited about. This is something I think is going to be happening in the next 5 to 10 years. So these are some of the SADS disorders. There are things like long QT syndrome, short QT syndrome, Brugada syndrome, CPVT, also known as catecholaminergic polymorphic ventricular tachycardia, idiopathic ventricular fibrillation, and arrhythmic cardiomyopathy. All of these, as you know, can cause missed beats of the heart, electrically destabilizing the heart, which can lead to life-threatening arrhythmias. All of these are also genetic. And what does that mean? This is how I think of genetics. A gene is sort of like a cookbook and a recipe within that cookbook to make something. The cell uses that recipe through a message called mRNA, which moves that message into the main part of the cell, which actually can make that recipe. And the recipe in this situation makes an ion channel. That's the kind of blue and green thing right here. And so if you have a good recipe, you can make a good ion channel. And that ion channel is needed to keep the heart electrically stable. With every beat of the heart has to depolarize and repolarize, electrically fire and reset. And that has to be coordinated. And if it's not, there can be instability electrically. Now, what if there was a misspelling in that recipe? I think of misspellings as kind of two different types. This type is a single word change or a single letter change in that recipe. Say 1 cup of flour for 10 cups of flour, right? That would still make a recipe, but that recipe would not be right at the end. I am not a baker, but I can imagine if you add too many cups of flour to a recipe of cookies, your cookies are not going to be very good. They still may come out, but they're not going to do their job. So just like that single spelling error changes the recipe for a batch of cookies, a single spelling error in a SADS gene leads to a protein that may be there, maybe not, doesn't quite work, okay? And that recipe means the heart is electrically unstable. You can also have a big change in the gene, something that throws off the entire recipe such that the recipe ends. You can't actually follow through with the recipe. In that situation, you may never even get those cookies. And these are the kinds of mutations that we're talking about: single nucleotide changes, single spelling errors, or big changes, loss of function changes. And different SADS conditions have different kinds of mutations. Making sense? Okay. We can leverage what we know about these genetic causes to customize your care. I'm a pediatrician, and so I don't like sticking kids with needles, so usually we go for cheek cells. That's what these are. But cheek cells, like blood cells, have DNA in them, and we can look for that misspelling in the DNA to find the molecular diagnosis for the SADS condition. And if we can, that gives us lots of information about what went wrong in that recipe and how best to fix it. So we can take, these are cheek cells. We can extract from these cheek cells DNA, find the exact misspelling in the DNA. You all see it here? There's a double peak. Where there's one peak, where there should be one peak, there's actually two. That's the misspelling. And that single misspelling is enough to throw off this thing, which is a picture of a potassium channel. And this potassium channel, well made, just doesn't work the same. And that's enough to give you a loss of function. So this is a science experiment where you can actually say, how much does that potassium channel move ion current through it? Big waves are good, small waves are bad. And just with that spelling error, that G to an R at position 245, that single change in the recipe, the cookies are made, but they don't taste very good. And that's a loss of function of that sodium channel. And that's enough to give you long QT syndrome, that one single spelling error. Traceable back to the DNA so that we can tell you the entire mechanism of how that disease occurs, and that gives us tremendous power to individualize your care. There are lots of different SAD conditions. There's lots of different genetic conditions that can lead to our various diagnoses. These are just some. And depending on the type of mutation that you have, one can develop one kind of SADS conditions or another kind. I'll show you one example. This is SCN5A. Has anyone ever heard of SCN5A in this room? The sodium channel, maybe? Some hands, some nods. SCN5A is a gene, a recipe, that encodes the cardiac sodium channel. One kind of mutation can lead to long QT syndrome when that channel doesn't close right. A gene mutation in that same area that causes the ion channel to not be made or not work well leads to Brugada syndrome. Okay? So one example of how one gene can lead to two different diseases. But again, understanding this genetic process and understanding how these genetic changes cause changes in the heart cells is incredibly important, and we can leverage that to provide better care. So if you've been on Twitter lately, you may have seen Mike Ackerman mention that anybody with a SADS condition should get gene testing. I agree with that. And that's because the gene testing allows us, like we've been talking about, to identify that misspelling in that gene that leads to the arrhythmia syndrome. And we can do a number of different things with that. The first and most important thing, in my opinion, is to find that mutation and to see if anyone else in the family has that same mutation too. Because even if they don't show any clinical signs of disease, having that spelling error means they're still at risk. Doesn't mean they're going to develop disease in the same way, but it means they're at risk and need to be followed. Whereas somebody who doesn't have that mutation, you can take a step back and say, well, their risk of having the family's disease is effectively zero. They have the same risk as everyone else in the general population of getting diseases, but the risk from the family is zero. So that's very important. But in the past 10 to 15 years, because of some tools I'll share with you, we've really pushed forward into how that gene mutation can actually go beyond risk stratification for the family into things like precision medicine. That is, how do we treat an individual based purely on their individual characteristics, even including their DNA, and how can this mutation inform risk? And this is where there's been a lot of really cool science I'm excited to share with you. This is an example of a positive gene test. Somebody who has long QT syndrome with a mutation in the gene KCNH2. This is one of those potassium channels. And this is a pathogenic variant, something we can act on. So how do you take a gene mutation like this beyond risk stratification in the family and use it to treat a patient better? Well, have any of you heard of long QT syndrome? I presume some of you have. There are lots and lots of different kinds of long QT syndrome. There are three major kinds of long QT syndrome based on just how many people have mutations in three major genes. You're seeing the big three right here. Long QT type 1, which are due to mutations in KC and Q1, it's a potassium channel. Long QT type 2, another potassium channel called KC and H2, and long QT type 3, SCN5A. There are risk factors for having potentially life-threatening arrhythmias that are specific to each of these genes. So not all long QT patients are the same. If you're a long QT type 1 patient, your risk is a little bit higher if you're swimming. If you're a long QT type 2 patient, things that startle you, particularly loud sounds, can be a risk factor. And for long QT type 3, sleep can be a risk factor. There are also individualized therapies based, again, on the gene and your specific diagnosis. So, for example, CPVT, catecholaminergic polymorphic ventricular tachycardia, beta blockers work great, and sometimes flecainide can be helpful as well. Conversely, long QT type 1 and 2, remember those are two potassium channels, beta blockers work great. If you have long QT type 3, beta blockers can work really well too, but sometimes mixilotine could be added. Brugada syndrome, beta blockers are not very helpful, right? So understanding the genetic diagnosis and the clinical diagnosis is really important to provide customized care for you. Not all SADS conditions are the same. Have you all heard anything about gene therapy? Oh, this is going to be great then. Gene therapy is any genetic modification to a cell, like a heart cell, that produces a therapeutic effect. And this is really a phenomenal thing coming up that I think is going to really revolutionize care. It's not today or even tomorrow, it's a few years down the road, but gene therapy, just based on its name for SADS conditions, relies entirely on understanding the genes. Thus is going to be individualized, right? I'll share a couple of examples. I don't see Mike Ackerman here. This is actually Mike Ackerman's work. This was a big deal when it was published. As you know, Mike's been very interested in looking at gene therapy for long QT syndrome. This is long QT syndrome type 1. You might recall that's because of mutations in KCNQ1. Most people have mutations in one copy. Did you know your DNA has two copies? You've got two copies of every gene, aside from the sex chromosomes. Most people with long QT type 1 have a mutation in one gene, but they have a normal gene that works well too. And so their cells make two different potassium channels, one that's mutated, one that's not. What Mike has done, some come back in the room, has figured out a way to suppress the bad mutant ion channel before it ever makes it to the membrane, and then give back a normal ion channel. That's remarkable. That's remarkable, right? And as scientists, we want to see the evidence, because you can claim all you want that you've done something. I want to see your evidence. This is remarkable evidence. So what you're seeing here are tracings of the firing and resetting of single heart cells on these lines. Your x-axis here is time. So the longer that tracing goes out, the longer that heart cell is taking to reset. Okay? So would you believe me if I told you that red line, you can't see I'll just point. That red line is taking longer to reset. Would you believe me if I told you that was a long QT cell, taking longer to reset than the normal cells? And what happens when you do suppress and replace? That time normalizes. Okay? So this is in a heart cell using single cell studies. But when you quantify it, you can shorten the individual QT of that individual cell, which is pretty remarkable. Brugada syndrome. Has anyone heard of Brugada syndrome here? Yeah. Brugada syndrome is a very challenging disease. There is really no good therapy for Brugada syndrome, right? No good medicines. We talked about beta blockers not being the best thing for Brugada syndrome. This is work that was led by a colleague of mine, Ninad Bursak, who's actually a cell electrophysiologist and a biomedical engineer, which are two very important fields that he's managed to combine in a lot of training. Brugada syndrome is caused by this, which is a sodium channel. This is what's made in our hearts that allows our heart to fire. The trouble is, if you wanted to put this sodium channel into a gene therapy, you run into a problem. Brugada syndrome, this channel doesn't work. So what you would love to do is take this channel and just simply reintroduce it into a cell. Our method for doing that is a virus called AAV. AAV is too small to fit the entire sodium channel in. Nanad thought of a solution. He thought, let's think small, let's even think microbial. Bacteria are much smaller than our heart cells. So he came up with an idea. What if we could identify a small bacterial sodium channel that was like the big cardiac sodium channel that you and I all have? Up top here is a diagram of what our cardiac sodium channels look like. It's got these 4 big domains that are roughly equivalent to each other, and those all fold together to form a big cardiac sodium channel. There is a bacterial sodium channel that looks very similar to one of those monomers made by E. coli. And that fits in AAV. And so his idea was, can you take this bacterial ion channel, put it into cells, and express? We played a small role in this. We didn't do all the heavy lifting. This was Nanad. But I'll share with you one slide of data. Doing this is kind of a big deal because it's really novel. You're trying to show that you can move a bacterial ion channel into a heart cell. So the first set of experiments that we did was we tried to express this in mouse cardiac myocytes. Every cell that you see there in green is a cell that's expressing BACNAV, the bacterial ion channel. And it electrically moves sodium just like the sodium channel does in the heart. And you can see that here with these big waves that show sodium flowing into the cell. And it's very, very similar to the sodium channel that we see in our hearts. And so Nanad is very interested in moving this into a gene therapy in mice. There are mice that have Brugada syndrome, believe it or not, and potentially in larger mammals and hopefully someday humans. So let's pivot a little bit and talk about how we might be able to predict SADS disorders before they ever manifest. And this whole discussion is really made possible by the precipitous fall in the cost of sequencing a human genome. So back in 2001, when the first human genomes were sequenced, they cost about $100 million. It took about 10, 15 years to do. Really expensive, right? Now, less than $1,000. And at Duke, we can sequence a whole genome in an afternoon for about $800, which is wonderful. So that changes things, right? An echocardiogram is a lot more than $800. And so the test is actually easy to do, it's cheap, and that's opened up a world of possibilities. What's the promise of this technology? Well, right now, it's sick babies in the ICU who are seeing a lot of the promise of precision medicine. You may have heard of neonatal ICUs. These are ICUs for little tiny babies. You may have had some personal experience even in these ICUs. There's a lot of babies there who are just sort of stuck. They're sick, we don't know why. The best doctors come around, they can't figure out what's wrong with the child, and this child just sort of is stuck in this ICU. Not getting better, sometimes they get worse. Whole genome sequencing in these children has revolutionized their care. So if you take these infants who are stuck, no one knows what's going on, you do whole genome sequencing on them and their parents, you will arrive at a diagnosis about 1 in 2 of these children, 50% of the time. That's a game changer. In addition, by figuring out what the diagnosis is early in life for that child, you save the family, you save that child, the healthcare system, tons and tons of time. You've heard of the diagnostic odyssey, right? Maybe some of you have been on that diagnostic odyssey where you see doctor after doctor after doctor, test after test after test, and then finally you arrive at a diagnosis. Well, in these 1 in 2 children, you can arrive at that diagnosis early, and it saves the healthcare system money to the tune of upwards of $2 million per person. So this, I think, is going to drive utilization of whole genome sequencing in the NICU, and it already has. In addition, this can be done rapidly. So this is work by Stephen Kingsmore out of Rady Children's Hospital. This is amazing. They took these children, no one knew what was going on. They rapidly sequenced the child, both parents, used artificial intelligence to pull keywords from the chart. They took humans out of it. They merged in AI the records with all the sequencing variants they found and were able to arrive at a diagnosis in less than 20 hours for these children. And that was 2018. This is amazing. This is game-changing. And I think in our lifetime, probably in the next 10 years, a whole genome is going to be our newborn screen. right? But with that promise comes a lot of challenges. I love this cartoon. So if you can't, it's a little bit blurry, but if you can't really see it, Kermit's sitting across from a doctor saying, "Have a seat, Kermit. I got something to talk to you about." And he's a puppet, right? So he was not expecting to figure out that he was a puppet. But these types of tests oftentimes have untoward consequences, and we call these incidental findings. The American College of Medical Genetics has said, okay, we know you're going to be doing whole genome sequencing. We know it's important. You may be doing it for a child who you don't have any concern for cardiac disease, but we want you to know if you find mutations in cardiac genes, they may be a SADS condition. And so you owe it to go back to the family and to the physician who ordered that test to let them know they've got this diagnosis, this genetic diagnosis. They put through a list of genes. You might recognize some of these. Most of these are actually cardiac genes. All of these on this list are cardiac genes, but most of the genes that the American College has flagged as being important are cardiac genes, and a lot of these are SADS genes. And if you look at large populations, right, these are ostensibly healthy individuals. These are huge populations where they've done genome and exome sequencing. 5% of individuals will have an incidentally identified variant in a gene that's flagged by ACMG that should be reported back to them as actionable, something that you need to know, something that your cardiologist needs to know. 1% of them are cardiac genes. So what's the problem with that? Well, unfortunately, that 1% is actually much, 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 much higher than the population of SADS people, right? And so there's a lot of signal and noise here. Some of these mutations will absolutely cause disease and should be flagged and should be returned. Many of them will never cause disease. And so we just need to get smarter about how best to pick out the sick babies who are at risk and the sick babies who are not at risk. And there's lots of work going on in this space that is very, very exciting. There are people who are advocating for genome first, right? These are individuals out at Rowdy Children's. We've talked about Stephen Kingsmore, folks at Seattle Children's, and even here at Baylor. And I think what you're going to be seeing is genome entering very early in life, and potentially SADS arrhythmia syndromes being caught day of life 1, 2, 3, if we can properly figure out which variants we have to worry about. And that is going to revolutionize care. And you can imagine if you pair that with gene therapy, you might be able to even cure the disease before it manifests. I think that's the dream. Long way to go. One thing to caution about here, this is a family of women who were told that they have a mutation in the BRCA cancer gene, the breast cancer gene. And they were told it was severe. And these women got bilateral prophylactic mastectomies because of this risk, only to find out that that mutation actually probably wasn't as disease associated as we thought. So just one counterbalancing point to highlight that while there's tremendous inertia in this field, I'm very optimistic about where we're able to go. We have to keep in mind families like you, families like them, and just be sure that we're doing this in a responsible way. And the last thing I'll leave you with is a tool that I think helps gets us there. Have you all heard of stem cells? So in my mind, there's two kinds of stem cells. There's the embryonic stem cells, and then there's induced pluripotent stem cells. The latter are what I'm showing you here. These are stem cells we can create from anybody. A sick baby in the ICU. My dad, who this year will turn 76, we can make stem cells from him. And from these stem cells, we can create any tissue we want, including cardiac myocytes. And you see them beating away here. Right? So cardiac myocytes taken from the blood of a child. This is an incredible tool that we can use to help figure out whether mutations may cause disease and to figure out more about SADS conditions that we need to know more about, like Mike mentioned, the ones where we don't know the positive gene test. So tremendous tool, a tremendous reason, I think, to be optimistic about what the future brings. And so in closing, genetic testing is important for all SADS conditions. The details of that gene test can confirm an individual's diagnosis, guide therapy, help identify risk factors for arrhythmias. Gene therapy is a promising target down the road for many SADS conditions and may be individualized. And we're moving towards predicting SADS conditions based on genetics, but many challenges remain so that we know who is at risk of developing disease. And with that, thank you for your time. Happy to answer any questions you may have. Ma'am. Cord blood? Yeah.
Is that helpful at all? Any of this?
Uh,
Oh,
so the question, for those who may not have heard, is can cord blood be used to make, I presume you're talking about the stem cell work?
yes,
Anything, yeah. So cord blood, like any other tissue, will have DNA from the baby. Sometimes mom's DNA gets in there a little bit because of the birth, and so you have to really be careful. I think the major tool for cord blood is actually they grow great stem cells.
How long until the gene therapy is in human trials, and where do you sign up? How long until the gene therapy is in humans,
Yeah.
and how do you sign up or get on the list?
Yes. Well, you're in luck because you've got Mike Ackerman here to talk about timeline for his gene therapy. I think the important thing to think about is what I've showed you today is gene therapy in cells. We need gene therapies in small mammals, right, with intact hearts to look at toxicity and efficacy. And then we need gene therapy in very carefully done trials. There have been trials even now where the individuals have had very late complications, a year or two, even after the initial therapy went in. So there's tremendous promise, but we have to do it responsibly. Sir.
So I'm a similar line of gene therapy. So I'm a parent to a child with CPVT. So obviously gene therapy is very exciting for us. But to turn that around a lot, as a parent, what advice would you give when assessing risks to such a new therapy? So I think in the next 10 years, hopefully I'll have options, and we're going to have options between gene therapy. Something so new, like what risks should we be looking to avoid when we have discussions with our doctor or with our treatment plan?
Yeah. I think the key for gene therapy is that it's incredibly exciting. But there is so much that still needs to be worked out about the best way to deliver in a way that doesn't cause side effects. What gives me pause is there's some trials right now that look very, very efficacious, meaning that they do a good job of fixing the disease. These are non-cardiac diseases. The challenge, though, is sometimes people very, very late get complications, and they can be life-threatening. So I think for me, the individuals who are kind of front of the line for that are probably not children, because I think children offer a very different dynamic in this sort of quest to finding a good therapy. I also think that if you're well managed, that gene therapy may not be front of mind for you, mainly because with the therapies that they're receiving now, you know what those side effects are. Versus gene therapy down the road, we don't know what those side effects are long term. Eventually we'll get there. But I think the individuals who are probably front of line for gene therapy are the ones where it's very significant disease. You've been through all the therapies, and nothing is working.
Any other questions? I encourage you, if you feel like I'm just about to ask it, but I don't know if I want to, now's the time to do it. Otherwise, we will, yes.
for long QT, 10 years ago, we were at a conference, and outside of long QT 1, 2, and 3, there was talks of other versions that are maybe not discovered or officially known yet. Has there been any updates on other versions of long QT?
There are. Mike Ackerman shared a couple of those updates yesterday. There have been some rare genes that have been discovered. I think the challenge with rare gene discovery is that the tools are so good now that if there is a rare gene that explains the remaining third or so of long QT syndrome, it probably would have been discovered a while ago. I think rare genes are going to help chip away at that, but those rare genes are going to remain rare, maybe even one or two of potentially in the entire world. The remaining, may be areas that we're not looking at in the genome. So right now, when we do a gene test, we look at what's called the exons, the areas that make that recipe that we talked about. There's lots of stuff in between those exons. lots of stuff between the recipes, the genes, that we don't normally look in. And if those have mutations that alter the recipes that we know about, that's another area. And there's also the chance that smaller variants around the genome, lots of little things compile to make a long QT phenotype. So there's a lot of work still being done.
Yeah.
I don't know if it's needed, but I have CPVT, and it's more adrenaline induced. But is there other like activities or things that have been noticed where it comes out more? Or you have seen the condition?
In terms of CPVT risk factors?
I guess just for helpful to anybody, I guess.
I mean, I think in the past few years, it's been just more reaffirmation that those high adrenergic states, the lots of adrenaline states, are really what drives the arrhythmia. I think there's been great work done about medical therapies and sympathetic denervation therapies and how they can work together for patients that maybe have a lot more breakthrough than just on medical therapy alone. I think the biggest shift in the past few years has been, at least in children, kind of a move away from putting ICDs in every single last one of those children, knowing that those ICDs can have complications, and sometimes if you can manage that individual without the ICD, that risk-benefit changes. So I think in terms of just overall therapy, that's what's been happening. But in terms of like new risk factors for sudden death in CPVT, I'm not aware of like new things that have come to light in recent year or two. Mm-hmm. Thank you.
Thank you, Andrew. We will have more time for panel discussion and informal connections. So if questions do come up, we really do encourage you to engage.